So welcome back, everyone, to OSU Research Day, and it gives me great pleasure to introduce Dr. Noah Ivers, who will be moderating the next session on the theory and principles behind implementation science, as well as a couple of examples from our OSU family. Dr. Ivers is a family physician at the Women's College Hospital. He's also a scientist at the Women's College Hospital Research Institute and an innovation fellow at the Women's College Institute for Health System Solutions. And I'll turn it over to Noah to moderate this next session.
Thanks, Dean. I'm a little shorter than you. So wonderful to see everybody back from lunch. Hopefully you're full. I have a big task, and that is we can start the timer if you like. 12 minutes or less. It will be less. There we go. Teach you everything about implementation science. I asked Vasanthi for 12 hours, but she wouldn't go for that. So I'm gonna just introduce the principles, because so much of what we're meant to be doing over this next number of years is not figure out how do we work together or figure out what ought to be done, but start figuring out how to put what ought to be done into practice. And that, at the core of it, is what implementation science is supposed to help us with. So I'm going to hopefully introduce some concepts that will be useful as we all think about putting evidence into practice. And I'm going to do it in just a few minutes, and then really hand over the mic to the stars of the show so they can tell you about their amazing projects from there. So this is, before the before days. The idea was you produced some evidence, you got it into a guideline, and then from A on above, you followed that guideline, just as we all in this room adhere to the 10 Commandments. And so, then the job was done, really. You found out what to do, you knew it would get done, and, that would be amazing. The problem is, repeatedly we find, decades and decades of health services research shows that, people don't just follow the guideline. Guidelines don't self-implement, is what I'm fond of saying. And so this field of implementation science emerged to try to shorten the gap between what we knew ought to happen and what does actually happen in the real world. And that required leaning on a whole host of social and behavioral sciences, because ultimately, if you want to make what ought to happen actually happen reliably, you need people's behavior to change. Somewhere along the line, somebody's behaviors need to change if things are going to happen differently. And so that means, incorporating processes and evidence and methods from poli-sci, from behavioral science, from social sciences, but also from health services research and the like. And so before we sort of go further, understanding some basic language, and I'll use an example as we go through this, just to make it clear what we mean when implementation scientists like me think about solving a problem. And so, efficacy research or effectiveness research thinks about how do we find evidence to, what's the right thing to do in a given clinical situation. So this is what we, most of our research is efficacy and effectiveness research. It's figuring out what's the thing we want to do or not do in a given situation. To use an example that we can all relate to, we can think about antibiotic prescribing. You've all been in a situation where you've had a cold or your child has had a cold, and you all know in the back of your head somewhere that most of those colds are from a virus and that antibiotics are not so good for viruses and they cause side effects, and we all know that antibiotics ought not to be prescribed for virus. But we've probably also all been in the situation where your sinus really hurts or your kid is really unhappy and you think, just give me the antibiotic. And so there's this gap between the thing that ought to happen or not happen in the case of antibiotics and what actually happens in the real world. Implementation research is about figuring out how do we make the right thing happen more often. How do we do or not do, in the case of antibiotics, the thing? And so when we talk about implementation strategies, we're thinking about what are the things we can put into that clinical interaction or before it or after it so we can make sure the thing happens properly, reliably, in the way that it's supposed to. And we measure implementation outcomes. That's not whether the thing happened, but actually whether we put in those things in the environment to cue the processes or the strategies to occur in the way that we would have wanted. So it's a bit of a mind shift. What we're focusing on is sort of downstream from the effectiveness questions that we need to sort out first. All right, so when we go to advanced science, yeah, I'm doing well on time. When we go to advanced science around implementation, we need to ask arguably 4 questions. And this was laid out by my friend Simon French. It's really sort of, it's perfect for me as a family doc because it's basically implementation science for dummies. And so it asks these 4 questions. Who needs to do what differently? So thinking really carefully about the different actors involved. If we think about the antibiotics, who's involved? It's parent and child, often. It's sometimes the front office staff checking the person in or making the appointment and how quickly they make the appointment. Who else is involved? Obviously the clinician or the prescriber. Who else is involved? The pharmacist dispensing or not dispensing. You know, you can think through the whole pathway and all the different actors involved and what they might need to do differently so we ensure the right thing happens every time. Now you've thought about the actors, you want to ask, well, why aren't each of these people doing each of these things at each of these steps in the way that we would have hoped? And there are structured frameworks we can use to think about all the various, comprehensively, all the various things that could play a role in them asking for that antibiotic, even though they kind of know in the back of their head that they probably shouldn't. And so then, once we have those laid out, hopefully in a structured and comprehensive way, we can map those factors to proven strategies that would address those underlying factors. So those underlying factors might be issues of motivation or opportunity or capability, or other ways that we can think of things that drive behavior. And there's 100 years of behavioral science research that helps us understand how to change behavior once we've, well identified and delineated what's going on. And then of course, if you're a scientist like me, you want to measure how well it went once you've gone out in the field and try to make a change. So just to sort of reiterate these points, basically to say that this is not rocket science, implementation science. When we want to put a change into the field, we can ask these 4 questions, and that can help us a lot. But what the science offers us from implementation research and the multitude of fields that implementation science builds off of are sort of structured frameworks and theories and strategies to think through how do we answer these 4 questions. So we can use structures and frameworks to think about the different actors in the pathway. Likewise, we can think really systematically about what are the contributors to a given behavior, to a parent calling up for that appointment because their kid has a fever, all the way through to the clinician when it's 4 o'clock on Friday, actually, saying it's much faster to prescribe the antibiotic right now, and so on. And there are a whole bunch of research studies that show us when we've identified those factors, how do we map them to strategies that are feasible in a given context, and how do we choose of those long list of potentially feasible strategies, which ones we should try in this scenario. And then, of course, like I said, there's the issues of measurement. This is my chance to sort of add in that, when we're thinking about evaluating implementation science, we want to make sure that it's happening, this is all about making the right thing happen more reliably, right? The antibiotic to not be prescribed when it ought not to be prescribed, the right thing to happen for the person living with heart failure so that they don't bounce back to hospital, et cetera. That's just sort of the start of a segue. And so we have to think, when we say reliably, we mean that it happens in a fair way, in an equitable way, for all the kinds of patients who might present with this kind of condition. So, essential to measuring how well we've done implementation research is thinking about it from an equity-informed lens. And I don't think we do that really well unless we, engage patients along the way. So there's the sort of main thing that I want to say. There'll be time for questions for sure, but I promised that I'd cede the mic to the stars of the show. I think Doug is up. There he is. So, Doug, are you happy to introduce yourself? This is Doug Lee. He has run an amazing trial around heart failure. He's going to tell us about it. And it really, I think, in many ways, sort of addresses some of the issues that I've raised.
Thanks. Okay, thanks very much. I'm a cardiologist at University Health Network, and I lead the cardiac program at ICES. And we were one of the awardees of an impact grant from the initial phase of OSU. And I'd like to share with you what the trial was about and what's happened since the trial. So we focused on acute heart failure. So when people with heart failure come to the emergency department, how can we improve, how can we change our strategy to improve outcomes? And to put this into context, believe it or not, over about a decade of research, there have been no drugs or strategies that actually have been demonstrated to improve outcomes in acute heart failure patients. And so we embarked on a complex strategy, a complex intervention that involved two main components. The first is a risk stratification method, which we developed, called the eMERGE risk algorithm. And that is shown on the left here. It is an algorithm that helps using routinely available covariates what the risk of patients are. It's kind of like a stoplight approach: red, yellow, and green. The green identifies low-risk patients who could potentially go home, who might not need to be admitted to hospital. And if they did need to be admitted to hospital, could potentially be discharged early. The red are patients who are high risk, who have a high probability of an event happening, and we generally recommend that those patients be admitted to hospital and not sent home. And in the yellow are intermediate risk patients, and we generally recommended in this trial that low intermediate risk patients could be sent home, and high intermediate risk patients should be admitted. So we coupled that with a strategy, and as shown on the right side, that lower risk patients could be directly discharged home from the emergency department or admitted for about 3 days or less, and then they could be seen in a rapid follow-up clinic in 3 days. The ideal would be about within 3 days. And they would get what we call transitional care, that they would get all of the care that they would have gotten in the hospital, but they're going to get it in an outpatient clinic. And it is run by a nurse, a clinician, and overseen by a cardiologist. And then at 30 days, that care would be handed over to either a primary care physician, a internist, a cardiologist, or heart failure clinic, depending on their needs. And then higher risk patients would be admitted to hospital. So this was a stepped wedge randomized trial, and the control arm was no risk stratification and no rapid heart failure clinic. And we were able to really do this because I gotta say, like, give a plug for OSU here, that we were able to do this because we were brought together with Ottawa Method Center, ICES, Women's Exchange, who helped us to design the study. So the results of the trial were that there was a reduction in the primary outcome of death or cardiovascular hospitalization within 30 days. There was a 12% relative risk reduction, which was significant. There was also the benefits were maintained out to about 20 months. And when we looked at hospitalizations, there was a significant reduction in cardiovascular hospitalizations. So you can see here, there's about a 16% reduction in cardiovascular hospitalizations out to about 20 months. And so we reached our primary endpoint, and there was the added benefit of reducing hospitalizations as well. And so it was published in the New England Journal of Medicine earlier this year. And so now we're at the stage of what do we do now? How do we get this to hospitals so that people are using it? And that's what the rest of this talk is about. And we, at our hospital, we are implementing this same strategy in a quality QBP demonstration project. So we took this strategy, applied for funding, to Ontario Health, and it is a demonstration project. And so, it is a part of several pathways that involve primary care, ambulatory care, cardiology, general internal medicine, emergency departments at Sinai Health, University Health Network, and Women's College Hospital. And a central part of this is using the risk score to help doctors decide what to do with the patient to supplement their decision making, not to replace their decision making. So this slide shows the pathway. So patient presents to the emergency department as part of in this pathway that we have now implemented at UHN, the score is calculated. The emerge score is calculated for risk stratification. The patient is then triaged, and there's a decision made to admit the patients to the hospital or to consider early discharge. And if they're considered for early discharge, there is an integrated care lead who helps to coordinate and navigate their care. That includes outpatient specialty visits in general internal medicine or rapid clinics as well. Technology-enabled care, so if the need is there, to use remote patient monitoring to monitor the patient or virtual follow-up. And then accessing home and community care, as well as involving primary care in the patient's care. And so this there's a lot happening after patients leave the hospital. And so the aim was really kind of the central aim was to incorporate the emerge model to the emergency department to rapidly identify heart failure patients, to risk stratify them, and then to triage and choose the appropriate pathway for the most appropriate care. This was launched in March 2023 of this year. So in the process of implementation, there was a lot of work, a huge amount of work behind the scenes. I can't take most of the credit for this work. There are teams of people who had dialogue and sought input on the pathway design from several of these multidisciplinary team members. We did rounds and training on the pathway and how to calculate the emerge score, which is currently available freely on the internet, and anyone can go in there and access the score. And then we identified champions within the emergency department and an integrated care lead to help to kind of bring this study to help take this study off the ground. We provided interpretive guidelines for the score, and then we uploaded a primer onto our EHR, EPIC. One of the things that we found in the process of implementation is that having the score, having a dedicated integrated care lead in the emergency department to help busy emergency physicians calculate the score and bring it forward to them is quite important. And it is kind of a temporary solution in a sense until we can automate this, and we are actually implementing the score into EPIC. So EPIC is our health information system. So at the current time, we are developing the code and working with the application's developers to automatically draw out all of the elements of the score that are necessary from the patient's electronic medical record to automatically calculate a score, and that score will, as soon as the emergency department physician opens up the chart, will be able to see the score. Just like they would see a white blood count or a CBC or something else, any other lab test. So that would show up. And so I think that is a key aspect of what we are doing now in terms of trying to scale this up. And the code will be shareable to other hospitals that use EPIC as well. And so as part of this knowledge translation plan, we have a kind of a 3-phase plan where we'd like to expand out to other hospitals and other emergency departments in Ontario. And we will be seeking out collaborators, emergency physicians and nurses, specialists in various fields, primary care physicians, especially the digital health EMR teams, research and communications personnel, the OSU, who have helped us to kind of really catalyze some of these activities, and then Core Health and its community of practice members. This is kind of our three-phase plan. So we're at the stage of trying to identify local champions, analyze gaps and opportunities for implementation. And we're going to start at the sites that participated in the COACH trial. Interestingly, some of the sites that participated in the trial are continuing to do the COACH process without any additional funding or support. But some of the sites are not. And some of the sites are applying it in different forms. And so we'd like to explore what's driving hospitals to do this on their own, and what's at the other end of the spectrum, what are the barriers to doing it. And so we'll identify and prioritize, identify key stakeholders from each of the sites, and then identify specific challenges that they've encountered, what requirements that they have, and their readiness for broader implementation. In the second stage, we'll be translating the knowledge and translation strategy and refining and developing a product. What we hope to do is to develop case studies. And actually what we found was that when we did the trial and we were trying to explain to clinicians why it's important to calculate the score, the data of all of the the multiple publications that we did to come up with the score were important, but it was especially important when we could describe a case, like one patient, and the example of one patient who had perhaps a bad outcome because the score was not calculated. That probably had as much impact as some of the publications. And so we're going to try to use that strategy to identify case studies that will highlight successful implementation and outcomes of this tool and in various settings. We will develop infographics and tip sheets and develop a video as part of a toolkit that hospitals can use to roll out Emerge at their hospitals, and then disseminate products that sites can use to implement Emerge and some of the strategies that we've developed in the COACH trial at their sites. And then we'll monitor and gather feedback. So in summary, the COACH trial was a successful implementation of a pragmatic trial. We had tremendous support from OSU to get it off the ground. We were able to do this using administrative databases at ICS for outcomes analysis. And in the post-RCT implementation, perhaps just as challenging as doing the trial itself. So we're encountering that, but we're going to be focusing on trying to get the increased use of the score out there, and it perhaps will take a multi-pronged strategy. Thank you very much.
That was just fantastic, Doug. Thank you. We do have another speaker about to come up. It's Christian, yeah. And so just to highlight there, some of the things that happened was, we had the actors, the Emerge doc, the triage nurse, the person in, later on in the pathway all had to use this Emerge score that they'd never done before. It's a behavior change challenge. And you can see how Doug and his team are working through understanding what are the things getting in the way of getting that score used, and how do we overcome those barriers in a very systematic way, which is really, really exciting. So with that in mind, we'll switch gears to sort of a totally different context, thinking about pre-hospital care and sort of a team working with, I guess, paramedics in that context. So I'll cede the mic with that in mind. We're virtual, right? Yeah, okay.
Good afternoon, everybody. I hope you can hear me and see my slide. Thank you, perfect. So my team and I are extremely grateful to have an opportunity to engage with you today, and I want to start by apologizing for my inability to join with you in person. I will present our projects and some of its outcomes, but try to, throughout the presentation, keep a lens on its implementation. But briefly, just about the problem to be solved, There are over 1 million transports for patients with a suspected spinal injury in Canada each year. Less than 1% actually have a cervical spine bony fracture, and even half of this actually have a spinal cord injury. But we know that the damage happens initially at the time of the initial injury and not during transportation, yet all patients used to be transported with complicated immobilization devices. This is not evidence-based. It's often used for prolonged period of time, and there's very well documented consequences on patients and on healthcare resources. So the Canadian C-spine rule is a decision aid that was first derived, validated, and implemented for use by emergency physicians to help us remove these immobilization devices without the need for X-ray, and more importantly, without missing any single important injuries. But as you just found out, emergency physicians are increasingly busy, so it made more sense to try to teach the triage nurses also to apply the same clinical decision aid to remove the immobilization when they first assess the patients that the paramedic colleagues are bringing to us. But what makes even more sense is to allow our paramedics not to apply those immobilization devices in the field to begin with. The rule had to be validated by the paramedics because we had to remove 2 of its questions which were irrelevant to the pre-hospital field. And we did that in a way where the paramedics were assessing the patients with the rule and documenting what they would have done and if they would have transported the patients with or without immobilization. But because it was a validation study, they continued to immobilize every single patient for transport. We did this successfully, ultimately, and then we also implemented this protocol into a very single center study where the emphasis really was on safety. And I have to mention that at this stage of the implementation in pre-hospital field, we had some difficulty to convince grant agencies as well as our ethics board that this was a safe thing to do. And the attitude back then was, let's just let the doctors and nurses decide to remove this thing and just let's not take any chance and transport everybody safely with immobilization. And I just want to take a quick step back to the validation study. The validation study was initiated by a colleague of mine, and I kind of inherited the study when the recruitment was less than 30%. Because the paramedics didn't change their practice at that time, filling the documentation was onerous. It was just an added task to them, and it was voluntary to do so. But when we met with the paramedics, I have a background as a paramedic physician before moving to Ottawa and Montreal as well. So I had a very good rapport with our paramedic partners. And we kind of invented the concept of a study champion. So we did have recruited one very well-respected paramedic that took ownership of the study, promoted it from within, and was a resource for their colleague to ask questions as well, which was less daunting to ask the investigators. And you can see that recruitment increased significantly after we did this, and we've never not implemented a study without a study champion and involving them ever since. So fast forward many years, and the project that was funded by OSU and SPORE. In terms of implementation, we're also very grateful for this opportunity, which would not have been occurring otherwise, to engage with partners we would have never engaged with before. They're mentioned on the slide over here, not the least of which, and I'm going to just mention for now, the Clinical Trials Ontario. At our research institute, this was the very first project that was put through Clinical Trials Ontario. It certainly facilitated greatly the implementation of the study in terms of the ethical aspect of things, and especially when it comes to renewal, but also our engagement with patients for the first time in this trial certainly helped to change the narrative from just a question of safety to, I've been transported on, backboard immobilization. It really hurts, it's uncomfortable, and it really helped change the focus and facilitate reviews and approvals for the project. And as I've mentioned as well, paramedic partners were essential in the implementation of the study as well. So as a matter of fact, when we were asked to contribute a commentary to the CMAJ initiative from OSU and SPORE, we made a point that for us, patient engagement is extremely important, but so is engaging with our paramedic partners. We see them as equal partners in our team. And the study was quite ambitious, and I'm not going to read them all, but there were many objectives to be met, not the least of which were patient benefit and also system benefits. A lot of our paramedics hurt their back actually lifting these heavy stretchers or the patients on it when they're immobilized. So I'm going to come to the results in a minute, but so we implemented the study in 11 new sites in addition to where Ottawa had initially implemented the study. And what I wanted to spend a second to mention here, which is interesting when you do pre-hospital research, and this is a very, very simplistic way of seeing what our government structure is, but essentially under the government of Ontario, there's of course the Ministry of Health and Long-Term Care Land Ambulance, and they do have a medical advisory committee, which is composed of paramedics, but also the medical directors from each of the 9 pre-hospital regions in the province. Under each pre-hospital regions, there's a number of paramedic services, which are usually community or city-based. But essentially, this is all to say that the paramedics function and work under the medical license of a medical director. So under a series of medical directives, which are updated once every 5 years normally, they all have to work the same. So when you try to implement a study in a pre-hospital field, and this was news to our ethics boards as well, you have to have a special medical directive, quote unquote, for research. But once this is reviewed and approved by the Medical Advisory Committee of the Ministry of Health, Long-Term Care, Land Ambulance, it's implemented and all paramedics have to now adopt this new protocol. So participation is not voluntary anymore. That becomes their new mode of operation. Although with our study, they always had the ability, if they were uncomfortable, to transport the patient with full immobilization if they insisted. We also used a cluster randomized step wedge design, and it's not only just a great, powerful design, but particularly when it comes to implementation, in our case, our paramedic partners would not have accepted to participate in a study where there was a possibility for them to never implement the intervention. So in a step wedge, earlier or later, you're always promised at least the ability to implement the intervention. So briefly going back to our results, in the first step of the step wedge, where it used to be or supposed to be control, we expected 100% immobilization rates, but of course we suspect that some of our partners were a bit enthusiastic in applying their newly acquired skills and perhaps made some decisions that were not quite as part of their medical directives. But nonetheless, what you see in blue here is the success in decreasing the immobilization rates up till 3 months before the end of the study, where real life happened as well. And I spoke about the 5-year cycle. The Ministry of Health, 3 months before the end of the study, had an opportunity to review and change the guidelines for the next 5 years. So they implemented a rule of their own, which is called a spinal motion restriction, where most patients could be transported with or without a cervical collar, according to the Canadian C-spine rule, but without a backboard, which is really what is causing most pain and discomfort. So as per our study definition, our immobilization rates following the implementation of this by the Ministry of Health really plummeted. But that also created an opportunity for us to continue the trial just a little bit longer and pivot and study yet another intervention that was not really planned of the original design. So what this means really is we also had to train our paramedics to deal with 2 protocols together. And what this looks like is top right is you see someone that may have failed the Canadian C-spine rule and still require mobilization of their neck and yet be transported in a position that's just a bit more comfortable, not on a backboard as you see at the bottom. So ultimately, in white and blue is the original study, and in green is what we were given an opportunity to study further as well as part of the study as well. So we recruited a little over 6,000 patients in the study, pretty successful, of course, at decreasing the rate of mobilization. Not surprisingly, patients were much more comfortable and less uncomfortable. We decreased also the rate of diagnostic imaging and, as well, the risk of diagnostic radiation exposure. We also had a series of opportunities to complete some pre-specified analyses. It also allowed us to look at the different types of immobilization devices that are used by different paramedic services to see which ones cause less discomfort than others. We did study the SMR protocol that was implemented and rolled by the Ministry of Health, but for the first time ever as well, with Colin at Sick Kids and Amy Plint from CHIO, we were bold enough to implement the Canadian C-spine rule in a pediatric population for the very first time. So that's something that would not have been possible without our collaboration with SPOR and OSU. But also, this was the very first time that the Canadian C-spine rule had a formal cost analysis being done. And happy to say that for the 9 months of the study per se, just in the 11 sites that implemented the Canadian C-spine rule, and this is according to ICES data and collaboration, we saved $1 million worth of healthcare resources. We also had an opportunity to collaborate with Montfort and look at certain inequities, and not perhaps surprisingly, language barrier is a significant barrier to implementing this in the field, which also raises the possibility perhaps to address this with increasingly better technology with translations and perhaps decrease this inequity in the future. There are 9 anticipated publications from this project, and we're just now starting to write them up. Although we were quite busy presenting 2 abstracts per year for the last 3 years, and they were all very, very well received and popular. So the main results and the pediatric results were both presented as plenary at a national emergency medicine meetings. The pediatric abstract won a national pediatric award, and the cost analysis earlier this summer actually won a Choosing Wisely Canada award as well for its findings. Why has it taken us so long to implement all of this and to write it up? Well, the SMR is something that delayed a little bit the end of our study, but did create an opportunity to study yet another intervention. So we were grateful and successful at requesting a 1-year no-cost extension for the project. It would have been impossible to do this without the collaboration with ICES, although data linkage to their admin databases, they're not updated many times a year, and to translate our outcomes into the list of variables available in ICES, that took a little bit more time than anticipated. We did pace, so in terms of implementation strategy, we did pace the distribution and presentation of our abstracts. We felt that if we presented all the results in 1 year, some of these important findings would be lost in translation and perhaps not get the attention they deserved. And also, we're human. So the minute you stop a project, of course, the next priority is to work on the next grant application such that you can continue to have the resources to feed your team. So there's that as well to take into consideration. Our target benefactors, of course, are patients themselves and our paramedic partners in terms of being able to work more efficaciously and less chance to hurt themselves as well. But our target audience is primarily, in our case, the provincial policymakers and their medical advisory committee. The paramedic service and fire services are the ones most impacted by the results of our projects. We also need to think about our emergency physicians and colleagues as well, because when you see someone arrive with full immobilization, it's also your visual cue to remember to examine and assess their spine. So we have to collaborate with them as well. When patients no longer come with immobilization, we still have to evaluate to make sure that they haven't injured themselves in their trauma. We've been approached by first aid agencies already, the Red Cross, St. John's Ambulance, because they're also often transporting patients with boards and collars. And of course, members of the public. Certainly, they should be made aware of our findings and advocate for themselves as well. And when people get injured, they have to know that there's opportunities beyond perhaps being transported with full immobilization. But there's also now a menu of choices for policymakers. So, for example, we were invited to present our results at the state of Florida EMS, and they are absolutely not interested in adopting a strategy of spinal motion restriction as per the Ministry of Health, where most people are transported without a backboard. They're too risk averse for this, but they were extremely interested in implementing the Canadian C-spine rule instead. And even if there was a service or an agency that decides to mobilize everyone, we can also now at least recommend which devices are less likely to cause pain and discomfort. So to finish the talk and to put things in perspective, this is really almost 10 years of integrated knowledge translation with our stakeholders to reach the point where we're at. Certainly, engagement with patient advocacy and our patient partners and paramedic partners was absolutely essential in our ability to implement the study, but also implement its findings. OSU and SPOR played a major role as well in our ability to not just do this, but also expand our minds to even evaluating things like the cost analysis would have never happened without this collaboration. In our specific case, we had to engage with the policymakers at the very beginning of the trial because we needed their permission to even implement the trial. Thankfully, immediately at the end, they also allowed all of our sites to continue use the intervention until the final results were made available. And I'm happy to report that very recently, we were able to now present our final results to the Ministry of Health and its Medical Advisory Committee, and they've now adopted the Canadian C-spine rule for broad implementation to the entire province of Ontario. So we've shared our study training material with them, and we're just anticipating this coming in the coming months. So I guess we're still very much interested, and there's still a lot of work to do as well. The pediatric population needs to be developed further in our ability to engage with the pediatricians and let them use the rule as well. And certainly as the manuscripts will be written and published, there will be an additional opportunity to collaborate with OSU and the communication specialists to really maximize the impact and broaden the scope of who can adopt the Canadian C-spine rule outside even of Ontario. That's it for me.
That was truly a whirlwind. Thank you. I think we are low on time. What I want to do is sort of emphasize a couple commonalities and maybe a couple distinctions, if I may. And while I do that, if folks do have questions, just maybe think of them, and we should have time for a couple. So first of all, in both scenarios, we knew what was the right thing to do. It is good and right to do the eMERGE score. It is good and right to think about patients' discomfort and whether, in fact, they meet C-spine criteria for, being boarded up. The issue was, in these different contexts, how do we get the good and right thing to happen reliably? And we see that it's a bit of a journey. But there are some commonalities we see in both contexts: the incredible utility of local champions, with both projects. Distinct from each project, there's not really a role for policy change to get doctors to do things. Doctors, getting them to do anything is very difficult, policy or otherwise. But, policy change was, incredibly crucial on the paramedic side. So thinking about why different actors may or may not do different things and what are the levers we can pull for them, just common themes across. So that was me taking up time while you thought of your questions, and we have time for a couple if you do have some. Yeah. Perhaps I'll repeat the question into the mic when you ask.
A question I've been dying to ask with Doug Lee, and that was, what about patient preferences, heart failure patients who may really prefer.
Thanks, John. That's great.
May really prefer to be admitted when the score says you shouldn't be admitted. Does that score do anything to change what patients prefer? Other patients who may dread being admitted really want to go home, but what I'm just wondering, what's been the effect? What's been happening at the emergency room level of this new score, especially given the variety of patient preferences around admission?
Yeah, that was a great question. And so patient preferences were an integral part to the decision making. The score, we view it as like a test. When you come to the hospital, doctors will do a blood test and say, okay, did you have a heart attack, yes or no, and make decisions based on that test. We view the score as like a test. It supplements doctors' decision making, but what happens, the decision whether patients are admitted or discharged, that's a process that involves the doctor and the patient, so they're an integral part. So in the trial, if they were low risk, if patients were hesitant to go home, they were still admitted to hospital. I think if there were social circumstances or other extenuating circumstances, they were admitted to hospital. These considerations were largely based on the input we had from our patient panel members. Actually, our patient advisory started in an OSU meeting. where we were first speaking with patient partners on the design of the trial, what considerations we have, and then we had specific input from patients. So all along the way, we had excellent comments like these. And the short story is that the patient's opinion mattered crucially, and if ultimately it was kind of a joint decision-making process.
Wondering if we have one more, perhaps something for Christian? Well, the iPad died. So I don't know if there was anything online. Sorry. Any other questions? Oh, good. O'Neill, go ahead.
So if you look at in your, from the C-spine rules publication in 2001. Thanks. So Christian, from the C-spine rule publication in 2001 to its policy change in 2023, there's a 22-year gap, and you showed all the different studies. But if changing a policy at the ministry, at the provincial level, made the rates plummet by, reduced by, 30 or 40%, what would you have done differently in 2001 to maybe, shrink the gap there?
Yeah, the challenge back 20 years back was that it was very much paternalistic, and perhaps I would say the respect that we provide to our paramedic colleagues today was a little bit different 20 years back, and the attitude was very much that they were often considered as a transport service rather than healthcare professionals with the ability to implement proper clinical decision making. And I would say, thinking back to the comments we were receiving from ethics board reviews and also from grant agency reviewers, even just 15 years ago, it was very much highlighting the fact this situation in that the attitude was very much just don't waste any energy, transport them with full immobilization, don't take any chance, and let the fancy doctors and nurses evaluate them and do this. And I think it took a little bit more time for the profession to develop, for the respect to get heightened as well. And I think the patient's voice was truly important in this manner. They were helping us to make the point that this is often unnecessary. This is so uncomfortable and painful. There's studies out there showing that if we took any of you and put you in immobilization devices for even just 30 minutes, by the time the doctors would evaluate your back, you would have pressure points and sores that would make them think that you need an x-ray. And we know that you didn't hurt yourself. So I think it's an evolution of attitudes over time that allowed us. I think we were just at the right place at the right time, and I would dare say that 20 years ago it would have been impossible to be where we are now. It was a combination of accumulation of science, having the right partners, and also change in attitudes over time.
Good. Well, great to thank you, Noah and Doug and Christian, for an excellent session, and certainly sends a message of the power of patient-oriented research and implementation science and why it's needed. Thank you very much. Yeah.